Dear Chair, dear audience and colleagues, welcome to my presentation. My name is Flóra, Olasz, and my PhD topic is complex therapy for children with cleft lip and palate. Before I talk about my topic more, I'd like to introduce myself a bit further. I am a first-year PhD student and a second-year orthodontist resident at the Department of Pediatric Dentistry and Orthodontics at Semmelweis University. Me and my supervisors have a clear mission of understanding the complexity of the cleft's origin and care, and we'd like to achieve that through researching different etiology factors and treatment possibilities. Working in the clinic have gave me the great privilege of working with children that has orofacial cleft, and it swiftly has drawn to my knowledge that they need way more research, way more knowledge, and way more awareness, since it's not a very awareness anomaly. This brings me to my first topic, which is researching the therapy possibilities through a systematic review and meta-analysis. It's called Investigating the Effectiveness of Presurgical Therapy Possibilities for Unilateral Cleft Lip and Palate in Infants. I'm sure all of us wants to have children at one point, or some of us wants to have children at one point, that we want them to be happy and very healthy. But little do we know that cleft lip and palate is one of the most common congenital anomalies affecting the craniofacial region. One out of 800 babies, one is born with this anomaly. And it also there's a combination in the etiology factors, so it can be a combination of genetics and environmental factors, and also the frequency of cases differs in different races in the different countries. The malformation occurs in a very, very early age, so it occurs in the first 5 to 12 weeks in the utero, and it happens when the palatal shelf fusion gets disturbed for some reason. Why is it important to raise awareness of this? Because the babies that are born with this condition have a very hard time breathing, swallowing, and also breastfeeding as well, and later on has many, many different malfunctions, such as when it comes to chewing, speaking, or even hearing. And also not to mention the aesthetic reasons as well. This is when our role comes in as orthodontists, when we can use a therapy options called the presurgical nasoalveolar molding, short for PNUM. You can see it on the upper left for you, which is an acrylic plate. When we see the babies, when we first meet them, which is around 2 weeks, we create an impression. We have a molding from then, and the technician creates this acrylic plate. Once we have the acrylic plate, we place it into the baby's mouth with a removable appliance glue, and we also use labial tapes, which helps the labial segments go closer to each other, and a nasal stand for nasal function as well. It has to stay in for 24 hours, and the parents remove it once a day to clean it. We see them every 2 to 3 weeks, where we actually take out the plate and we kind of manipulate it, so we drill out of the acrylic so we can guide the bone into a specific way where we want to grow them. Why is PNUM good for us? First of all, it helps us guide the bone into a specific way, so it will make the cleft smaller. And also it helps give lung function, so using the plate, they can properly learn to swallow, they can properly learn to feed, and they also can breastfeed, which gives back the basic function that they're missing at this point. This brings me to my clinical question, which is how efficient is PNUM treatment in UCLP? We used the PICO frame, which we looked into infants with UCLP. And then we looked into 2 groups. One was the PNUM treatment group, the other one is the non-treatment group, and the outcome that we were looking for was cleft shrinkage. This is my hypothesis, which is PNUM treatment is more efficient than no PNUM treatment in infants with UCLP. And we conducted our systematic research in 3 different databases. We ended up with around 500 articles. As you can see, it's a barely researched topic, and out of all the data extraction, we got down to 5 articles that we could use. Before I explain my final analysis a bit further, let me explain the outcome a bit more. So then on the left, you can see a normal palate, and on the right, you can see a cleft palate. As you can see, there's a massive gap between the 2 maxilla segments, and usually on 3 to 6 months, this gap gets closed via a surgeon, so it's surgically closed. As you can imagine, it does matter whether they have to close a 5 centimeter or a 3 millimeter gap. So what we want to do is, for some ways, to manipulate the bone to go closer to each other, so the gap that they have to close is way smaller. How do we do this? We use the PNUM, as I explained before. We drill out of the acrylic, so we help the bone into a guided growth as we want to do it. To measure it, to see whether if it's efficient or not, we have to take an impression in before the treatment and after the treatment, and then compare the 2 millimeters. So we use 3 different points in the maxilla for that. First, we want to look into the anterior cleft foot shrinkage, which is basically the one that we're expecting to be manipulated the most, since it's mostly the alveolar bone that we're manipulating. For this, we used 5 RCTs. As you can see, it's a pretty large sample size, and the heterogeneity for that is also pretty large, but it can be due to the slightly different protocols, and as you can see, the articles are from very different years, so that means that the technique also advanced throughout the time. We compared our 2 groups and before and after treatment, and as you can see, the cleft shrank 5 millimeters, which favors our PNUM group, and this is clinically very relevant since it means they could close a smaller gap when it comes to the surgeons. But unfortunately, because of the small amount of articles, this is mathematically not as relevant. We go to our second outcome, which is the intercanine region with shrinkage. From now on, we're actually expecting to have a smaller shrinkage. What we want to see is whether it stayed the same length or it shrank a bit, because obviously here, where you can determine from this whether the cleft got way wider or it stayed the same. So we used 4 RCTs for this one. Also large sample size, the heterogeneity was smaller at this point, and when we compared our 2 groups before and after treatment, you can see that it actually did shrink 0.5 millimeters, which means it favors our PNUM group, and this is also clinically relevant, but we do need more research on this since there's lack of very small amount of articles. We also looked into the posterior arch width, which is basically what we're expecting is the same thing. This is the one that can be manipulated the least. So what we see here, also 4 RCTs, large sample size, and when we compare these 2 groups together, you can see that it also shrank. So this means it also favors our PNUM group, meaning that using this acrylic plate helps the cleft to actually shrink in a way. Our strengths were, when it comes to the articles that we use, that they were all blinded randomization process. We had a large sample size compared to the fact that they're all babies. We had the same inclusion and exclusion criteria, and when it comes to the limitations, unfortunately, they were using different infant orthopedics. Also, there's a very small number of articles and a high heterogeneity due to the facts that I already mentioned before. But our conclusion, seeing these results, that we can say that using PNUM treatment is actually efficient when it comes to the anterior cleft region. So for implication as it comes to practice, this should be generally involved in the cleft care. And for research, we do need to actually look into more of also the intercanine and the posterior width as well, to see whether they have more options or not, and we do need a guideline as well. This is my first project's flowchart. I'm working on my manuscript right now, and I want to publish in the Journal of Dentistry, hopefully this summer. So up until now, I've talked about the therapy options or researching the therapy options for these children. I want to get more involved in the etiology factors as well, which I like to do through a retrospective case control study in seasonality and birth month of patients born with orofacial cleft between 1960 and 2023 in Hungary. As I explained before, this is a multifactorial anomaly. So obviously we knew sort of what happens when it comes to alcohol or drugs. We don't know whether anything of the environment, for instance, sunshine, wind, or anything has to do with that. And all the studies that we looked into are offering conflicting conclusion. So we do need more studies to see whether environment has more factors or is it just a myth. As you can see, it's a highly researched topic, so people from Iran, Australia, Sweden, Finland, they're all looked into whether it has a seasonality when it comes to these anomalies. And luckily, we have a Hungarian congenital abnormality registry where you can see all these data that we're having. And from there, not with orofacial cleft, but with other abnormalities, they already did a check, and there is a seasonality when it comes to other abnormalities. So we'd like to see whether orofacial cleft has a seasonality. This brings to my clinical question, which is there a monthly birth rate pattern in patients born with orofacial cleft? We looked into babies born with cleft lip and palate. We were exposure using month, and the outcome was using different birth rates. Our hypothesis is that there is a seasonality in the birth rate of babies born with orofacial cleft. And whether we can see if there is, we can look into more etiology factors if they had anything to do with the birth. Working with these children, obviously, we can see that orofacial cleft is a very demanding anomaly when it comes to time, patient, mental health, and also physical health. So it's only our privilege to be able to research it better, to know it better, and also to treat them better. So I'd like to thank you for your attention with a quote of Stephen Hawking: "The greatest enemy of knowledge is not ignorance, it's the illusion of knowledge." Thank you very much.
So congratulations to your first project. I just want to ask about the risk of bias for the first project, because you mentioned as a strength that it's all blinded studies.
Yes.
But if I understand the treatment well, it seems to be pretty visible, like who get the treatment, this treatment, and who doesn't. So who was blinded in this case?
When
Assessors?
when they were, thank you for your question, sorry. When they were first alleging whether the babies that are born, so they had 40 babies and they were assessing to which group to get into, this is what was a blinded process was happening. And also once they had the moldings, that was also a blinded way of actually measuring the millimeters. So they didn't know whether they were measuring a baby that had the PNOM or they didn't have the PNOM. Also, we're talking about millimeters and a mold, so this could have been saying they didn't know which one to bring.
Thank you for your presentation. I would like to ask if there are any contraindications for babies regarding your first project.
Thank you for your question. There are. So first of all, what I'd like to, the obvious reasons, for instance, if they have any different illnesses that would need hospitalization or anything, that they cannot attend hospitals every 2 to 3 weeks. Also, I think what is very important is the parents, whether they're willing to help us in this treatment, because it's one thing what we're doing, and the most important thing is what they're doing at home. So if they're using the tape regularly, if they're using the acrylic plate regularly, so if the parents are not really cooperative, I would say then it's kind of eliminating them from these trials, and also whether they have any allergic reaction either to the plate or to the glue or to the taping as well. These are the ones.
Thank you.
Thank you so much.
Congratulations. My question would be regarding the situation here in Hungary. Is there a consensus between the clinics that whether they use PNAM or not, or is there a difference between the different universities implementing PNAM?
Thank you for your question. Unfortunately, there's no, as I mentioned before, there's no gold standard or treatment for this therapy because, for instance, I would name 2 bigger universities that work with this technique. One of us would be Semmelweis University, and I'm not naming the other, but for us, it's not even a question that we're using it. For the other clinic, they are not using it regularly and not the way we're using it. So I think it would be very important to have proof to see whether this is something that we all should generally use. So thank you for your question.
Thank you.
Really nice results, congratulations. I was about to ask that is there any center in Hungary that are using the molding, but this question was set. So let me ask you that for how long is molding available for specialists and for children?
How long is it available for? So what we do is we take the first one in like the first 2 weeks when we see them, and usually they grow out of like around 1 month. So we usually take around 2 to 3 different acrylic plates. So as they grow, we change the plates as well. So they use by the 3rd one by the time they go to surgery, but they're always personally made for them.
Thank you very much.
Congrats, very interesting project.
Thank you.
I had a question. So I saw in 2 first plots, I think it was intercanine and posterior arc width. Surprisingly, one of the articles, when they applied PNAM, there was increasing the width of this arc and not decreasing. Did the authors explain why this could happen?
Thank you for your question. They didn't specifically talk about that. It also, as I mentioned before, it has a lot to do with parents, the worrying time, whether it's in the mouth or not. So it also, what we see in our practice, whether we're using the same protocols, they have the same cooperants and everything, even babies can react to it very differently. It's such a personalized thing. So I think it has so many ways to go wrong, if it makes sense, that it could be probably because of that.
Thank you.
Thank you.